So it's my great honor to give the Tomisaku Kawasaki Memorial Lecture at the IKDS here in Canada. Now, Dr. Kawasaki has been a looming presence across my career, a true legend and rock star, ever gracious when approached by admiring amateur paparazzi, and adored worldwide by the families who have been touched by the disease that bears his name. So it's now been 63 years since Dr. Kawasaki encountered his first patient with an unusual complex of symptoms, careful documentation of which he filed in his God only knows or who knows what file. Another case followed a year later, and Dr. Kawasaki was quick to connect the two. More cases followed, all of which he carefully documented and culminated in 1967 with the first publication in Japanese of 50 such patients. Now, the level of detail he reported and the connections he drew between the cases was extraordinary. In 1970, a surveillance was organized which sounded the alarm about associated coronary artery involvement. And 1974 saw the publication in English in pediatrics of Dr. Kawasaki's original case series. And through this publication and word of mouth, cases began to be described elsewhere, most notably in Hawaii by Marian Mellish, who reported 16 cases in 1976, the year I graduated high school, by the way. Kawasaki disease was now on the map. So decades later, we continue to grapple with more unknowns than knowns and a plethora of clues. I'm not going to go over this slide because this is the obvious things that I think everybody in the room can agree upon. But I assume we all know this. Now, the questions, however, that we persistently grapple with include questions about the etiology and pathogenesis, how we might be able to prevent, predict, diagnose, and mitigate Kawasaki disease and its coronary involvement and consequences, and then how we can achieve an effective precision medicine approach, the catchword in medical care today. So my own decades-long experience with Kawasaki disease, including attending and contributing to these meetings, has led me to this one take-home message I would like to expand upon. So in his initial report, Dr. Kawasaki speculated about the etiology of the condition he described, stating that, however, various investigations, such as those described above, have not provided us with a definitive answer to the question of whether it is an infection caused by a specific bacteria or virus, or if it is due to a non-specific infectious allergy or some type of autoimmune mechanism. And this, I think the speculation about the cause led to what was the initial treatment at that time being antibiotics and steroids. Now, for the rest of Dr. Kawasaki's life, into his 90s, he would sit in the front row of meetings such as this one, patiently waiting for someone to tell him the cause of the disease that he had first described. Hence, much of the focus has been on determining which one microorganism is the culprit. Initial investigations focused on known pathogens, and more recently on what I call things floating around, and even unknown or presumed new organisms. Organisms from our own microbiome have also been considered, and indeed lactobacilli in Canada have been used as inciting agents in purported animal models of Kawasaki disease. But associations come and associations go. While we have heard perhaps way too much about coronavirus lately, it has come up in the past. I remember at the IKDS in 2005 in San Diego, chaired by Jane Burns, the hot topic was the purported association with a novel coronavirus in New Haven, Connecticut, where during an outbreak, 75% of KD patients versus 5% of patients, matched control patients, tested positive. So during the meeting, this association was debated, and shortly after its subsequent publication, there were a series of studies in different populations that refuted this discovery. Now fast forward to 2020 and we're at the start of a global pandemic with yet another new and more pathogenic coronavirus. And within weeks, a severe hyperinflammatory syndrome in older children with clinical features similar to Kawasaki disease was first reported and spreading rapidly, filling pediatric ICU beds with patients who had shock and ventricular dysfunction, among other organ systems affected. Its similarities to KD suggested the need for prompt and aggressive immunomodulatory therapy, which proved effective. Interestingly, during the early stages of the pandemic, Kawasaki disease diminished. However, it appears now to be on the rebound. The clinical parallels between KD and MIS-C prompted early speculation as to whether MIS-C might be a specific form of KD where the trigger, SARS-CoV-2, is known, unlike for historical KD. Ongoing examinations of both the similarities and the differences, particularly on an epidemiologic and pathophysiologic level, will likely lead to new clues and maybe some new answers. Perhaps somewhat similar to Dr. Kawasaki, but not as well organized as him, I have my own who knows what file. I had noted two seemingly identical patients, both aged 2 years, who were diagnosed with complete KD 8 days after a scald injury, both responding to IVIG and both having no coronary artery involvement. Now at the time, we hypothesized that the KD could have been triggered by the entry of an infectious agent, a toxin, or a superantigen through a compromised skin barrier. Now subsequent similar rare cases were reported, and then in 2020, Okada and colleagues reported a case of KD after a severe sunburn injury, and a more detailed investigation showed the presence of high serum levels of mobility group box 1, an endogenous damage or danger-associated molecular pattern, or DAMP, implicated in the pathophysiologic models of KD. Now, this experience highlighted to me that perhaps KD was more complicated than a single thing, and that there were many such reported associations that, when retained and pondered and even connected, might fit into an etiologic and pathophysiologic model. Now, I am not an immunologist or a rheumatologist. I'm a cardiologist with some epidemiologic expertise. And if you press me regarding my knowledge of PAMPs and DAMPs and IL-1 and a lot of the things that we were just presented, you might find that I'm swimming very much in the shallow end of the pool, looking at the deep end, which looks very dark and murky to me. And this is somewhat frustrating at times. But epidemiologic associations interest me, particularly forgotten ones or hard to explain ones. Now, when I joined the faculty at the Hospital for Sick Children in Toronto in 1992, I inherited the KD population from Dr. Vera Rose at her retirement, and not because I had any particular expertise. Now, one association being debated at the time was an association of KD and recent rug or carpet cleaning, noted during an outbreak in Denver, Colorado, of 52 cases. Exposure was noted in 62% of KD patients versus 20% of matched controls. Now, while dust mites were suggested as the etiologic link, this was never verified, and the association seems to have been lost, not explainable, and not replicated. I was particularly interested when I first heard that Kawasaki disease might be blowing in the wind. In 2011, it was first reported that tropospheric wind patterns were associated with outbreaks of KD spatiotemporally in Japan. Further work published in 2014 using simulations with a flexible particle dispersion model from different Japanese cities suggested that the source region for an implicated agent were the cereal croplands of northeastern China. Aerosol sampling in the atmosphere suggested a prevalence of Candida species, an agent known to induce a KD-like condition in an animal model. The investigators concluded that their work suggested that the causative agent of KD was a preformed toxin or environmental agent rather than an organism requiring replication. They proposed a new paradigm whereby an idiosyncratic immune response influenced by host genetics, triggered by an environmental exposure carried on the winds, results in the clinical syndrome known as acute KD. However, the environment should be viewed as more than just the delivery system of an immunologic trigger. Environmental factors are very important in early life in immune system development and modulation. The immune system is a key principle in the developmental origins of health and disease. Both the adaptive and innate immune systems are trained systems, programmed early in life by exposures to naturally occurring substances such as heavy metals, and more recently, synthetic compounds. Additional factors include prenatal and pregnancy factors and exposures, nutritional factors, and microbial and allergen exposures. If we are to prevent KD, we will need to focus on these factors and promote optimal immune development and health across the lifespan. Now, building on our previous work regarding spatiotemporal clusters of Kawasaki disease in Canada, under the leadership of Cedric Manlio, we aim to integrate an ecologic or systems approach to the etiology and epidemiology of Kawasaki disease. We embarked on a multi-pronged study published in 2018 aimed at linking clues regarding etiology and pathophysiology, building a model that might predict the incidence of Kawasaki disease globally. The first part was a classic case control epidemiologic patient-level surveys focused on the habitual environmental exposures, including the use of filtered or bottled water. Actually, we noted that KD patients were found to have less habitual environmental exposures, including the use of filtered or bottled water, fewer pets, younger age of their homes, and situated in areas with less tree coverage and less proximity to a body of water, park, or farm. KD patients were also noted to have increased preceding infectious symptoms or confirmed infections, and interestingly, were less likely to have had a rotavirus vaccine. A second part of the study linked KD cases from Toronto with atmospheric data regarding biologic particles and wind data. Periods of increased biologic particles were associated with decreased KD cases, and westerly winds were associated with increased predominance of fungi imperfecti. The third part enumerated the reported annual incidence of KD in every country or region where the information was available and analyzed for epidemiologic associations. A model that included the proportion of the population that were of Asian ancestry, the proportion of the country that was urbanized, the gross national product, and the country's geolocation from Northeast China predicted 84% of the variation in global incidence. Together, these studies demonstrated the importance of environmental factors, locally, regionally, and globally, to support the importance of an ecologic or systems approach. Now, based on our findings, we broadened our team and secured funding and aimed to define this in greater detail using Canada-wide data. We mapped KD cases spatiotemporally across Canada, linked this with population characteristics from Census Canada, healthcare encounters from administrative data, and data regarding weather and pollution and atmospheric particles. We used, and when I say we, I mean Cedric used, a Bayesian disease model approach, creating a base spatiotemporal model adjusted for age and ethnicity, and examining the incremental improvement in that model with additional epidemiologic and environmental factors. Now, this exercise led to this etiologic framework for Kawasaki disease, whereby genetic immunologic predisposition determined baseline immune susceptibility that was then modulated by immune system maturation, early childhood and environmental factors, and exposure to immunological irritants, that acted to determine the trigger and the type and magnitude of the immunological response to a potential trigger, exposure to which was mediated by environmental factors. And there's a reason why the trigger thing is a black box, because as far as I'm concerned, it is still a bit of a black box. One outcome, if the circumstances were right, would be the patient would clinically manifest as known Kawasaki disease. Now, the nature and complexity of the implicated immunologic pathways are likely not uniform. This framework can then be used to explore possible associations for observed epidemiologic and clinical associations. Now, I often believe that if we could just pull all the various clues together, including insights from other diseases and fields, then we might come up with the one answer. And I remember some time ago asking Cedric that if we could comb through and synthesize the vast internet of information, we might be able to come up with an answer. Now, this was technically not possible at the time I first posed the question, but prior to this conference, I posed the same question to again, and now we have ChatGPT, although he directed me to something he thought was better, Claude, and the output was a listing of all the various known clues without any integration, but with a final sentence that stated, current scientific consensus suggests that Kawasaki disease likely results from a complex interplay of genetic susceptibility, environmental triggers, and a dysregulated immune response to an unknown infectious or environmental agent. The disease may represent a final common pathway for multiple etiologic agents or processes, which seems like a description of the framework that we had come up with. Now, Jane Burns, and likely many others, I know ponders this problem as well, and her recent and balanced article on the etiologies of KD likewise concluded that the etiology remains unknown, but is likely, presumably, multifactorial. Now, I would add to this that the application of machine learning techniques has suggested the presence of distinct phenogroups of KD, as noted by Jane Burns' group, and phenogrouping particularly in relation to KD's aggressive cousin, MIS-C, as noted by Cedric's work with the International Kawasaki Disease Registry. So KD may have more than one manifestation, and the factors driving the differences remains unclear. So my take-home message that I have landed on is that when it comes to Kawasaki disease, it's not one thing. Which brings me to the issue of treatment, which is also not one thing, and which is where I believe the real challenges will lie for the future. Now, being a pediatric cardiologist, I have found myself in a field of rare diseases whereby the management of one complex congenital heart disease patient may be heavily influenced by a similar previous patient or local experience rather than any wealth of critically appraised evidence. Kawasaki disease remains a rare disease with rare outcomes. And given the aforementioned complexity regarding etiology and pathogenesis, further optimizing management based on evidence will be particularly challenging. Empiric immunomodulatory therapy with IVIG has reduced the prevalence of aneurysms to slightly less than 4%, but further increments have been hard to come by. Newer therapies have to be studied on a background of IVIG, making it impossible to assess if a new therapy is actually better than IVIG. Biologics directed at specific immune targets are often targeted to patients who do not respond or who are predicted not to respond to IVIG. Given the rarity of aneurysms, there has also been an interest in targeting surrogate outcomes, although their relationship to aneurysms may be less direct or precise. While our focus has been on preventing coronary artery involvement, we also have to realize that many patients have involvement already present at the time that they present, and treatment aimed at halting progression or even promoting favorable vascular remodeling has been understudied. So we are entering the era of precision medicine, but we'll need robust and ever more comprehensive data to inform and improve prediction models. So my final take-home message has to be to recognize the overwhelming importance of global collaboration, which is something that's going to come up a lot at this conference. We need to break out of our subspecialty silos, cross disciplines and approaches, and lift each other up across the globe. We need global data, global investigation, and widespread sharing of knowledge and skills. In this, it is also not one thing, but everything. And yes, we need some money too. So Dr. Kawasaki exemplified several characteristics that we should all strive to emulate. We should always remain curious, asking questions, seeking answers. We should be astute observers and never dismiss those things that we can't explain or connect. Documentation is the key to data collection, from which synthesis can lead to new knowledge and new questions. And above all, we need to be compassionate advocates for our patients, our trainees, and our collaborators, working together with humility and grace. And so, to Dr. Kawasaki, I wish we could break open a barrel of sake here in Montreal and offer up a toast of respect and honor, but please accept my humble thanks. Arigato, Tomisaku Kawasaki, arigato. Thank you.